Q341. What is lung cancer? A341. Lung cancer is a malignant disease characterized by uncontrolled growth of abnormal cells in the lungs, leading to the formation of a tumor. Q3142. What are the main types of lung cancer? A342. The two main types of lung cancer are non-small cell lung cancer, NSCLC, and small cell lung cancer, SCLC, with NSCLC being the more common type. Q343. What are the risk factors for lung cancer? A343. Cigarette smoking is the primary risk factor, but other factors like secondhand smoke, radon exposure, air pollution, and certain occupational exposures can also increase the risk. Q344. What are the common symptoms of lung cancer? A344. Cough, hemoptysis, dyspnea, chest pain, and unintentional weight loss are among the most common symptoms of lung cancer. Q345. How is lung cancer diagnosed? A345. Diagnosis typically involves a combination of imaging studies, chest X-ray, CT scan, PET scan, bronchoscopy and biopsy to confirm the diagnosis and determine the histological subtype. Q346. What is the role of molecular testing in the diagnosis and management of lung cancer? A346. Molecular testing, including analysis of genetic mutations and biomarkers, is crucial for guiding targeted therapy and immunotherapy in lung cancer. Q347. How is lung cancer staged? A347. Lung cancer is staged using the TNM, tumor node metastasis system, which takes into account the size and location of the primary tumor, the involvement of lymph nodes, and the presence of distant metastases. Q348. What are the treatment options for early-stage non-small cell lung cancer? A348. For early-stage NSCLC, the primary treatment is surgical resection, often followed by adjuvant chemotherapy or radiation therapy. Q349. What is the role of targeted therapy in the management of lung cancer? A349. Targeted therapies, such as tyrosine kinase inhibitors and monoclonal antibodies, are used to treat lung cancers harboring specific genetic mutations or molecular alterations. Q350. What is the role of immunotherapy in the treatment of lung cancer? A350. Immune checkpoint inhibitors have emerged as a significant advancement in the treatment of both NSCLC and SCLC, particularly in patients whose tumors express high levels of PD-L1. Q351. How is small cell lung cancer, SCLC, typically managed? A351. SCLC is an aggressive form of lung cancer that is often treated with a combination of chemotherapy and radiation therapy, with limited options for targeted or immunotherapy. Q352. What is the role of radiation therapy in the management of lung cancer? A352. Radiation therapy is used in various settings, including as a primary treatment for early-stage disease, as part of combined modality therapy, and for palliation of symptoms. Q353. What is the significance of tumor genomic profiling in lung cancer management? A353. Comprehensive genomic profiling of lung tumors can identify actionable genetic alterations that guide the selection of targeted therapies and immunotherapies. Q354. How does the management of lung cancer differ in older adults? A354. Older patients with lung cancer may require modified treatment approaches to balance efficacy and toxicity, often with a greater emphasis on palliative care. Q355. What is the role of minimally invasive surgery in the treatment of lung cancer? A355. Techniques like video-assisted thoracic surgery, VATS, and robotic-assisted surgery can offer less invasive surgical options for selected lung cancer patients. Q356. What is the impact of smoking cessation on the management of lung cancer? A356. Smoking cessation, even after a lung cancer diagnosis, can improve treatment outcomes and reduce the risk of second primary lung cancers. Q357. How does the presence of comorbidities affect the management of lung cancer? A357. Comorbidities, such as cardiovascular disease, chronic obstructive pulmonary disease, and other malignancies, can significantly influence the treatment approach and prognosis. QLRT61. What is pleural effusion? A361. A pleural effusion is the abnormal accumulation of fluid within the pleural space, the area between the lung and the chest wall. Q362. What are the main causes of pleural effusions? A362. The most common causes are congestive heart failure, malignancy, pneumonia, and pulmonary embolism. Q363. What are the typical symptoms associated with pleural effusions? A363. Shortness of breath, chest pain, and cough are the most common symptoms of pleural effusions. Q364. How is a pleural effusion diagnosed? A364. Diagnosis involves a combination of physical examination, imaging studies, chest X-ray, CT scan, ultrasound, and thoracentesis, fluid aspiration. Q365. What information can be obtained from the analysis of pleural fluid? A365. Pleural fluid analysis, including cell count, chemistry, and cytology, can help determine the underlying cause of the effusion. Q366. What is the difference between a transudative and an exudative pleural effusion? A366. Transudative effusions are caused by an imbalance in fluid production and reabsorption, while exudative effusions are caused by increased permeability or inflammation in the pleural space. Q367. What is the significance of malignant pleural effusions? A367. Malignant pleural effusions are associated with advanced cancer and often require more aggressive management, such as pleurodesis or indwelling pleural catheters. Q368. How are parapneumonic effusions and empyema managed? A368. Parapneumonic effusions and empyema, infected pleural fluid, typically require antibiotics, thoracentesis, and sometimes chest tube drainage or surgical intervention. Q369. What is the role of thoracoscopy in the management of pleural effusions? A369. Medical thoracoscopy can be used to diagnose the cause of an undiagnosed effusion, as well as to perform therapeutic procedures like pleurodesis. Q370. What is the significance of recurrent or persistent pleural effusions? A370. Recurrent or persistent pleural effusions often indicate an underlying chronic condition, such as heart failure, malignancy, or autoimmune disease, and require further evaluation. Q371. How are chylous pleural effusions managed? A371. Chylous effusions, caused by the accumulation of lymphatic fluid in the pleural space, are typically managed with dietary modifications, somatostatin analogues, and in some cases, surgical intervention. Q372. What is the role of diuretics in the management of pleural effusions? A372. Diuretics can be useful in the treatment of transudative effusions, such as those caused by heart failure or liver disease, by addressing the underlying fluid imbalance. Q373. What is the significance of pleural fluid pH in the management of pleural effusions? A373. Pleural fluid pH can help differentiate between different types of effusions and guide the need for more aggressive interventions, such as chest tube drainage. Q374. How do pleural effusions affect respiratory mechanics and gas exchange? A374. Large pleural effusions can impair lung expansion, reduce functional residual capacity, and compromise gas exchange, leading to respiratory distress. Q375. What is the role of indwelling pleural catheters in the management of recurrent malignant effusions? A375. Indwelling pleural catheters allow for repeated drainage of malignant effusions and can improve quality of life for patients with advanced cancer. Q376. What is the significance of pleural fluid cytology in the diagnosis of pleural effusions? A376. Pleural fluid cytology is a crucial diagnostic tool as it can help identify the presence of malignant cells and guide the management of the effusion. Q377. How do parapneumonic effusions differ from empyema in terms of management? A377. Parapneumonic effusions may be managed with antibiotics and thoracentesis, while empyema often requires more aggressive interventions, such as chest tube drainage or surgical decortication. Q381. What is pulmonary embolism? A381. Pulmonary embolism, PE, is a blockage of the pulmonary arteries, usually caused by blood clots, thrombi, that have travelled from the deep veins, most commonly in the legs. Q382. What are the risk factors for the development of pulmonary embolism? A382. Major risk factors include immobilization, surgery, cancer, pregnancy, oral contraceptive use, and inherited or acquired thrombophilic disorders. Q383. What are the common symptoms of pulmonary embolism? A383. Shortness of breath, chest pain, tachycardia, and syncope are the most common symptoms of pulmonary embolism. Q384. How is pulmonary embolism diagnosed? A384. Diagnosis typically involves a combination of clinical assessment, D-dimer testing, and imaging studies such as CT pulmonary angiography or ventilation perfusion, VQ scanning. Q385. What is the role of D-dimer testing in the diagnosis of pulmonary embolism? A385. D-dimer testing is a useful initial screening tool, as a normal D-dimer result can help rule out pulmonary embolism in low-risk patients. Q386. How is the severity of pulmonary embolism assessed? A386. Pulmonary embolism severity is assessed based on the patient's hemodynamic status, right ventricular function, and the presence of shock or hypotension. Q387. What is the significance of right ventricular dysfunction in pulmonary embolism? A387. Right ventricular dysfunction is a marker of disease severity and is associated with increased mortality in patients with pulmonary embolism. Q388. What are the treatment options for acute pulmonary embolism? A388. Treatment options include anticoagulation, thrombolytic therapy, catheter-directed interventions, and surgical embolectomy, depending on the severity of the embolism. Q389. What is the role of anticoagulation in the management of pulmonary embolism? A389. Anticoagulation is the mainstay of treatment for most patients with acute pulmonary embolism to prevent clot extension and recurrence. Q390. When is thrombolytic therapy used in the treatment of pulmonary embolism? A390. Thrombolytic therapy is typically reserved for patients with high risk or massive pulmonary embolism who present with hemodynamic instability or right ventricular dysfunction. Q391. What is the role of catheter-directed interventions in the management of pulmonary embolism? A391. Catheter-directed techniques, such as mechanical thrombectomy or pharmacomechanical thrombolysis, may be considered for select patients with high-risk pulmonary embolism. Q392. What is the significance of recurrent pulmonary embolism? A392. Recurrent pulmonary embolism is associated with increased morbidity and mortality, and long-term anticoagulation is often required to prevent recurrence. Q393. How does the management of pulmonary embolism differ in special populations, such as pregnant women or elderly patients? A393. The management of pulmonary embolism in these populations requires special consideration due to the increased risk of complications and the need to balance the risks and benefits of treatment. Q394. What is the role of inferior vena cava filters in the management of pulmonary embolism? A394. Inferior vena cava filters may be used in patients with acute pulmonary embolism who have a contraindication to or failure of anticoagulation. Q395. What are the long-term complications of pulmonary embolism? A395. Long-term complications include the development of chronic thromboembolic pulmonary hypertension and post-thrombotic syndrome. Q396. How does the risk of pulmonary embolism vary in different clinical settings? A396. The risk of pulmonary embolism is higher in hospitalized patients, particularly those with recent surgery, immobilization, or cancer, compared to the general population. Q397. What is the role of thromboprophylaxis in the prevention of pulmonary embolism? A397. Appropriate thromboprophylaxis, using anticoagulants or mechanical devices, is crucial for reducing the risk. Q401. What is asthma? A401. Asthma is a chronic inflammatory disorder of the airways characterized by variable and recurring symptoms, airflow obstruction, bronchial hyperresponsiveness, and underlying inflammation. Q402. What are the common symptoms of asthma? A402. Wheezing, coughing, chest tightness, and shortness of breath are the hallmark symptoms of asthma. Q403. What are the main triggers for asthma exacerbations? A403. Common triggers include allergens, viral respiratory infections, exercise, cold air, air pollution, and certain medications. Q404. How is asthma classified by severity? A404. Asthma is classified as intermittent, mild persistent, moderate persistent, or severe persistent based on the frequency of symptoms and lung function measurements. Q405. What is the role of airway inflammation in the pathogenesis of asthma? A405. Chronic airway inflammation involving various immune cells and mediators is a central feature of asthma and contributes to the characteristic symptoms and airflow obstruction. Q406. What are the common risk factors for developing asthma? A406. Risk factors include genetic predisposition, atopy, exposure to environmental allergens, air pollution, and respiratory infections in early life. Q407. How is asthma diagnosed? A407. Diagnosis is based on a combination of clinical history, physical examination, and lung function testing, such as spirometry and bronchial provocation testing. Q408. What is the role of biomarkers in the diagnosis and management of asthma? A408. Emerging biomarkers like exhaled nitric oxide and blood eosinophils can provide additional information to guide asthma diagnosis and treatment. Q409. What are the main classes of medications used to treat asthma? A409. Inhaled corticosteroids, bronchodilators, short-acting and long-acting, and leukotriene modifiers are the primary medications used in asthma management. Q410. What is the role of inhaled corticosteroids in the management of asthma? A410. Inhaled corticosteroids are the cornerstone of long-term asthma control as they effectively reduce airway inflammation and prevent exacerbations. Q411. How do short-acting and long-acting bronchodilators differ in the management of asthma? A411. Short-acting bronchodilators provide quick relief of symptoms, while long-acting bronchodilators are used for long-term maintenance and control of asthma. Q412. What is the role of combination inhalers in the management of asthma? A412. Combination inhalers, containing both an inhaled corticosteroid and a long-acting bronchodilator, are often used to improve asthma control and reduce exacerbations. Q413. When are oral corticosteroids used in the management of asthma? A413. Oral corticosteroids are typically reserved for the treatment of acute asthma exacerbations or for severe, uncontrolled asthma cases. Q414. What is the significance of asthma control in the management of the disease? A414. Achieving and maintaining good asthma control with minimal symptoms and exacerbations is the primary goal of asthma management. Q415. What is the role of allergen avoidance in the management of asthma? A415. Identifying and avoiding relevant environmental allergens can be an important part of asthma management, especially in patients with allergic asthma. Q416. How does the management of asthma differ in children compared to adults? A416. Asthma management in children may involve age-appropriate medication dosing, consideration of growth and development, and addressing specific triggers and comorbidities. Q417. What is the significance of asthma exacerbations in the overall management of the disease? A417. Asthma exacerbations or acute worsening of symptoms are important events that can lead to hospitalization and increased mortality if not properly managed. Q418. What is the role of immunotherapy in the management of asthma? A418. Allergen immunotherapy may be considered for selected patients with allergic asthma. Q421. What is chronic obstructive pulmonary disease, COPD? A421. COPD is a progressive lung disease characterized by persistent respiratory symptoms and airflow limitation, typically caused by exposure to noxious particles or gases, most often from smoking. Q422. What are the main subtypes of COPD? A422. The two main subtypes of COPD are emphysema, characterized by destruction of alveolar walls, and chronic bronchitis, characterized by chronic airway inflammation and mucus hypersecretion. Q423. What are the common symptoms of COPD? A423. Dyspnea, chronic cough, sputum production, and wheezing are the hallmark symptoms of COPD. Q424. What are the major risk factors for the development of COPD? A424. Cigarette smoking is the primary risk factor, but other factors like occupational exposures, air pollution, and genetic predisposition can also contribute to COPD. Q425. How is COPD diagnosed? A425. Diagnosis is based on a combination of clinical history, physical examination, and spirometry, which demonstrates persistent airflow limitation. Q426. What is the role of lung imaging in the evaluation of COPD? A426. Chest imaging, such as chest radiography and CT scanning, can help identify the specific COPD subtype and detect associated complications. Q427. How is COPD classified by severity? A427. COPD is classified into 4 stages: mild, moderate, severe, and very severe, based on the degree of airflow limitation measured by spirometry. Q428. What are the main treatment goals in the management of COPD? A428. The primary goals are to reduce symptoms, prevent and treat exacerbations, and improve exercise tolerance and quality of life. Q429. What is the role of bronchodilators in the management of COPD? A429. Bronchodilators, including short-acting and long-acting agents, are the mainstay of COPD treatment to improve airflow and reduce symptoms. Q430. What is the significance of inhaled corticosteroids in the management of COPD? A430. Inhaled corticosteroids, often in combination with bronchodilators, can help reduce exacerbations and improve symptoms in patients with moderate to severe COPD. Q431. When is oxygen therapy indicated in the management of COPD? A431. Supplemental oxygen is recommended for COPD patients with resting hypoxemia to improve survival and quality of life. Q432. What is the role of pulmonary rehabilitation in the management of COPD? A432. Pulmonary rehabilitation, including exercise training, education, and psychosocial support, is a crucial component of COPD management to improve exercise tolerance and quality of life. Q33. How do exacerbations of COPD impact the management and prognosis of the disease? A433. COPD exacerbations, characterized by acute worsening of symptoms, can accelerate disease progression, increase the risk of hospitalization, and worsen the overall prognosis. Q434. What is the significance of comorbidities in the management of COPD? A434. Comorbidities, such as cardiovascular disease, lung cancer, and depression, are common in COPD patients and can significantly influence treatment approaches and outcomes. Q435. What is the role of smoking cessation in the management of COPD? A435. Smoking cessation is the single most important intervention to slow the progression of COPD and improve overall outcomes. Q436. When is lung volume reduction surgery or lung transplantation considered for COPD patients? A436. These interventions may be considered for select patients with severe emphysema-predominant COPD who have failed medical therapy. Q437. What is the impact of COPD on overall mortality and life expectancy? A437. COPD is a leading cause of morbidity and mortality worldwide, and it is associated with a significant reduction in life expectancy, especially in severe cases. Q438. How does the management of COPD differ in older adults compared to younger patients? A438. Older COPD patients may require modified treatment approaches to balance efficacy and tolerability. Choice 1. What is acute respiratory distress syndrome, ARDS? A441. ARDS is a life-threatening condition characterized by rapid onset of widespread inflammation and increased permeability of the alveolar capillary barrier, leading to impaired gas exchange and respiratory failure. Q442. What are the common causes of ARDS? A442. The major causes include pneumonia, sepsis, aspiration, trauma, and certain underlying medical conditions like pancreatitis and drug overdose. Q443. What are the typical clinical features of ARDS? A443. Patients with ARDS typically present with acute onset of hypoxemia, bilateral pulmonary infiltrates, and respiratory distress, often requiring mechanical ventilation. Q444. How is ARDS diagnosed? A444. Diagnosis is based on the Berlin definition, which includes criteria such as timing, chest imaging, origin of edema, and degree of hypoxemia. Q445. What is the role of chest imaging in the evaluation of ARDS? A445. Chest imaging, particularly chest radiography and CT scanning, is crucial for identifying the characteristic bilateral opacities associated with ARDS. Q446. How is ARDS classified by severity? A446. ARDS is classified as mild, moderate, or severe based on the degree of hypoxemia, as measured by the ratio of arterial oxygen partial pressure to fraction of inspired oxygen, PaO2, FiO2. Q447. What are the key principles of ARDS management? A447. The main goals of management include lung protective ventilation, fluid management, treatment of the underlying cause, and supportive care. Q448. What is the role of mechanical ventilation in the management of ARDS? A448. Mechanical ventilation with low tidal volumes and limited airway pressures is the cornerstone of ARDS management to minimize further lung injury. Q449. How does fluid management impact the outcomes in ARDS? A449. Judicious fluid management, often with a conservative fluid strategy, can help improve oxygenation and clinical outcomes in ARDS patients. Q450. What is the significance of extracorporeal membrane oxygenation, ECMO, in the management of ARDS? A450. ECMO may be considered for select ARDS patients with severe refractory hypoxemia or hypercapnia who fail conventional mechanical ventilation. Q451. What is the role of pharmacological interventions in the management of ARDS? A451. Pharmacological therapies such as corticosteroids, neuromuscular blockers, and novel anti-inflammatory agents have been investigated, but their benefits remain unclear. Q452. What is the significance of prone positioning in the management of ARDS? A452. Prone positioning can improve oxygenation and outcomes in ARDS patients by promoting more uniform ventilation and perfusion. Q453. How do comorbidities affect the management and prognosis of ARDS? A453. Comorbidities such as underlying lung disease, cardiovascular disease, and immunosuppression can significantly influence the management approach and worsen the prognosis in ARDS. Q454. What is the role of supportive care in the management of ARDS? A454. Supportive care, including sedation, analgesia, and management of organ dysfunction, is crucial in the comprehensive care of ARDS patients. Q455. What is the significance of long-term outcomes in ARDS survivors? A455. ARDS survivors may experience long-term sequelae, such as pulmonary fibrosis, neuromuscular weakness, and cognitive impairment, which can significantly impact their quality of life. Q456. How does the management of ARDS differ in specific patient populations, such as the elderly or immunocompromised? A456. The management of ARDS in these populations may require tailored approaches to balance the risks and benefits of interventions. Q457. What is the role of biomarkers in the diagnosis and management of ARDS? A457. Emerging biomarkers, such as inflammatory cytokines and alveolar epithelial and endothelial injury markers, may help in the early identification and risk stratification of ARDS. Q461. What is cystic fibrosis? A461. Cystic fibrosis, CF, is a rare, inherited, life-limiting disorder characterized by the production of thick, sticky mucus that affects multiple organ systems, primarily the lungs and the digestive system. Q462. What is the genetic basis of cystic fibrosis? A462. Cystic fibrosis is caused by mutations in the CFTR, cystic fibrosis transmembrane conductance regulator, gene, which regulates the function of chloride channels in epithelial cells. Q463. What are the common clinical manifestations of cystic fibrosis? A463. The main manifestations include chronic respiratory infections, pancreatic insufficiency, malnutrition, infertility, and elevated sweat chloride levels. Q464. How is cystic fibrosis diagnosed? A464. Diagnosis is typically made through newborn screening, sweat chloride testing, and genetic testing for CFTR mutations. Q465. What is the role of lung function testing in the management of cystic fibrosis? A465. Pulmonary function tests, such as spirometry, are crucial for monitoring disease progression and evaluating the response to treatment. Q466. What are the common respiratory complications of cystic fibrosis? A4666. Recurrent respiratory infections, chronic airway inflammation, bronchiectasis, and eventually respiratory failure are the major respiratory complications. Q467. How is the nutritional status of cystic fibrosis patients managed? A467. Pancreatic enzyme replacement, dietary modifications, and nutritional supplementation are essential to maintain proper growth and development in CF patients. Q468. What is the significance of cystic fibrosis-related diabetes? A468. Cystic fibrosis-related diabetes is a common complication that can further impair nutritional status and lung function if not properly managed. Q469. What is the role of airway clearance techniques in the management of cystic fibrosis? A469. Airway clearance techniques such as chest physiotherapy, oscillating positive expiratory pressure devices, and mucolytics are crucial for mobilizing and clearing the thick mucus in the airways. Q470. What are the main classes of medications used in the treatment of cystic fibrosis? A470. Antibiotics, bronchodilators, anti-inflammatory agents, mucolytics, and CFTR modulators are the primary medication classes used in CF management. Q471. What is the significance of CFTR modulator therapies in the management of cystic fibrosis? A471. CFTR modulators, such as ivacaftor and elexacaftor, tezacaftor, ivacaftor, target the underlying genetic defect and can significantly improve lung function and clinical outcomes in eligible CF patients. Q472. When is lung transplantation considered for patients with cystic fibrosis? A472. Lung transplantation may be an option for select CF patients with advanced end-stage lung disease who have failed medical therapy. Q473. What is the role of infection control and preventive measures in the management of cystic fibrosis? A473. Strict infection control practices, including airborne precautions and targeted vaccination, are essential to reduce the risk of respiratory exacerbations in CF patients. Q474. How does the management of cystic fibrosis differ in pediatric and adult populations? A474. The management of CF requires a multidisciplinary approach that adapts to the changing needs and challenges across the lifespan of the patient. Q475. What is the significance of mental health and psychosocial support in the management of cystic fibrosis? A475. Addressing the mental health and psychosocial needs of CF patients and their families is crucial for improving overall quality of life and treatment adherence. Q476. What is the impact of advances in cystic fibrosis care on the life expectancy of patients? A476. Significant improvements in multidisciplinary care and the introduction of CFTR modulators have contributed to a substantial increase in the life expectancy of CF patients in recent decades.